I'm going to try to make this informal. We have a small group, and so I can even take questions, and you can interrupt me. This has been a big year for Ibogaine with a lot of things that are happening. I want to just point out my conflict of interest. I'm the CEO, founder of DemeRx. I'm ex-faculty from the University of Miami Miller School of Medicine, and I've been working on Ibogaine for over 30 years. So this has been an exceptionally long journey for me. And I'm also a consultant to ATAI Life Sciences, who is taking the lead on the clinical development and paying for the clinical trials to advance Ibogaine as a medicine for the millions of people who are desperate to take it. Both Ibogaine and its active metabolite, noribogaine, which I want to teach you a little bit about, are indicated for the treatment of substance use disorders. As I mentioned, Ibogaine is currently in clinical trials in the United Kingdom, and these are the studies that are funded by ATAI Life Sciences. Noribogaine is currently getting ready to go. We're having another discussion. It has been in humans, and we're having a discussion soon with the FDA, and we're going to be commencing new studies with noribogaine. And we heard a lot from Terran Biosciences yesterday about psychedelic versus non-psychedelic molecules and analogs and ways to dose psychedelics for patients. And noribogaine is not a psychedelic molecule. So there are distinct things between the two. Ibogaine, I've been involved in this, as I mentioned, for 30 years, but this has over 100 years of ethnobotany and ethnopharmacology behind it. It is supported today by extensive observational data, or what we call anecdotal data. And one of my colleagues at NIDA used to tell me, Herb Kleber, he died, he was the former medical advisor to the drug czar, ONDCP, in our country, and he'd look at me years ago and he'd say, Deborah, data are not the plural of anecdote. So it's important, yeah. And you think about that when those of you that are psychedelic researchers, that we need to be able to bring the data sets together in a way that we can present to make this more mainstream. It's very important. But it is supported by extensive cases, and I'll talk about that. And why am I here? And this year has been a very big year. Ibogaine was a big topic at MAPS this year. I spoke to 1,000 people in a room at MAPS. It was amazing, perhaps one of the best talks I've ever given in my life. I also was invited to Breaking Convention in Exeter in the UK, and we had a tremendous Ibogaine panel. So there's a lot of interest right now, and of course Rick Doblin is a champion also of Ibogaine, as mentioned at the introduction. Why is this so important? Why do I care about this? Why am I so deeply passionate? I'm deeply passionate because we have a chemical weapon attack going on in our country today. 150 people die a day in the United States from opioid death, opioid intoxication deaths. That would be the equivalent of a plane crash a day in the United States. Think about that. What would the FAA say if a plane crash went down a day? When you think about addiction, I'm a neuroscientist, neuropharmacologist. I've been at this doing research studies on the brain for, again, many years in my academic role as a NIDA-funded investigator. What we've learned from neuroscience is that when, some of us may be at risk for getting addicted. Some of us may have tried cocaine or an opiate or took a prescription opiate, and we don't fall down the slippery slope. Other people may try it, feel normal, they start to self-medicate with the drug. You can imagine the example I like to give is a young mother who has a new baby. She does a C-section, her doctor prescribes opioids, and 30 days later, 60 days later, 90 days later, she's still taking opioids. That mommy probably has been self-medicating and perhaps even postpartum depression, which is common. These are the people who are at risk. So you feel normal on them, you feel better, they're anxiolytic, euphoria, and you're on your way. The problem is that an opioid use disorder, or drug addiction in general, is an acquired disorder of the brain. So your brain gets hijacked. There is plasticity that goes awry in the brain. And this is a very interesting topic, and I'm going to come back to that in later slides. But what happens is you're self-medicating with the opiate, and you're going through these little mini bouts of withdrawal over and over and over again. So it's almost like a kindling loop in the brain, yeah? And then you try to get clean, you stay clean, and then something triggers you. Stress is a big one, right? And so you get depressed, you have problems with your job, your family life is going sideways, and the stress comes up, and you think, I know what would make me feel better. I'm going to go out, just one more line of Coke, one shot of dope, one more Oxycontin, and you're right back out. And it's the memory. It's the memory of the painful withdrawal. Today, what's available? Well, this is a busy slide, and I'm not going to go through all of this, but basically what the FDA has approved, and everyone here knows about methadone, but buprenorphine or Sublocade is the primary medication, opioid substitution. So whether you take methadone or you go on Sublocade, which both of those drugs have helped millions of people, of course, I'm not saying anything negative about it, but you're treating symptoms. You're blocking withdrawals. It's substitution therapy. You're not dealing with the underlying illness or the hijacking of the brain. And so when you try to taper off of them, you're right back, you find yourself back in the same situation. Okay? And so that's why withdrawal and then is associated with very high relapse rates. Very high relapse rates. Naltrexone's an antagonist, again, bad relapse rates. So is it possible that Ibogaine fits in this last box? That it's not only able to block withdrawals, and it's very effective for blocking withdrawals, and you just have to Google that on the internet and you will find testimonials. But the other exciting thing is that it helps with a transition to abstinence. And for some people, not everyone, but for some people, it's remarkable. So treating acute withdrawal symptoms, Ibogaine, and then relapse prevention. And in the bottom, I have protracted negative affect. When you come off opioids, 30 days, 60 days, 90 days, those of you that work in 12-step groups or have worked, understand that that chip is red, right? That red chip, 90 days, high risk for relapse. So it was very interesting when we worked with this drug to see that it seemed to have an enduring effect, and it helped as what Howard Lutzoff taught me originally, which is that it's an addiction interrupter. This is the molecule. It's an indole alkaloid. The indole part of the molecule is right here. This part looks like serotonin, especially when you take off that methoxy group. 100 years used in Africa in the rites of, as a psychedelic, an African psychedelic, very powerful molecule in that regard. But for my neuroshaman females in the room, the Bwiti religion in the Western Equatorial region of Gabon and Cameroon believes that it is the women who handle the roots of the plant and prepares the sacrament for giving it to humans. This is a kind of a short summary of the history, the 100 years history from the first published account of the spiritual use. Interestingly, low doses of Ibogaine were marketed in France under the trade name Lamborine in 8 milligram tablets in French pharmacies, because a lot of the pharmaceuticals that were developed in the 50s, early 50s and 60s came from Mother Nature. And so people took low doses of Ibogaine. In 1985, Howard Lutzoff, he is credited with the seminal discovery of Ibogaine. Of course, used it himself. He himself suffered from heroin addiction. He did the original experiment with himself and some of his friends who were opioid users, and described for the first time that it blocked the withdrawal. Not only did it profoundly block withdrawals, but it also, they didn't want to go back out and get high again. and many of them stayed clean and sober, off dope, for months, and in fact, some for years. In 1989, clinics started opening up in different places, and in 1991, there was an activist movement to get the National Institute on Drug Abuse to put some money behind this, and here's where I come in, right here. This was me. Because I went to Amsterdam, and I took colleagues with me, and I met Howard Lutzoff, and I saw the drug work with my own eyes. And I was so amazed by this. I was amazed by the science, but I was also amazed that our country should get behind this immediately. And I was really naive, you know. I believed, everybody want this. So I went to the FDA, and despite a lot of roadblocks that came up against me, we got FDA permission in 1993 to administer a psychedelic at the University of Miami to people who were trying at that time to get off cocaine. But I couldn't get the money to fund it. There's more chapters to that. And in 1995, I went up in front of the NIDA meeting, and I've been a NIDA-funded investigator. I'm still a NIDA-funded investigator since, I don't want to tell you what year, 1992. And yeah, couldn't get the money. So this is what we did at the University of Miami, and we started. And what was interesting is the FDA was really very, very, very collaborative and very helpful. Some people say, why doesn't the FDA do something about Ibogaine and make it go forward? But the FDA was very collaborative. They don't pay for the studies, but they helped us. And in the 8 mg per kg, 10 mg per kg range, this we believe is a safe dose range, and it's a psychedelic range. So they actually let us go forward with high doses. And I'm showing you this because the blue line here is Ibogaine. So Ibogaine is out of the blood in under 24 hours, but look at noribogaine, the green line. So noribogaine has a very long half-life. And this was kind of interesting because we knew that the psychedelic journey was tied to the duration of Ibogaine in the blood, but when the curve crosses and the noribogaine is high in the blood, the visions cease. And then it washes out over a week. And I was actually able to detect noribogaine in the urine out to 3 weeks was the longest. So this looked like this setup where it's almost like a 2-stage rocket. Ibogaine brings about the transformative psychedelic experience, and then noribogaine may be mediating some of the beneficial after effects of the treatment. When I couldn't go forward in the United States, I did something really bold. I went to the Caribbean, and I set up the first government-approved psychedelic clinic anywhere in the world. 1996, we dosed 6 subjects in St. Kitts, West Indies. And we published, I held the data for many years. The clinic operated for many years. And we kind of stayed a little bit underground, keeping in mind that there were no clinics then. And the DEA was curious about what we were up to at the University of Miami. They came by to visit me a couple times. But they were happy with us, and we did our work. And in 2018, finally, they said, Mash, what is wrong with her? She's not publishing her data. And I published this paper. This is the largest 191 patients treated with Ibogaine, the largest case series to date. There are other publications in the field, but in this one, we documented many different things. One of the things that we were able to demonstrate is that Ibogaine has very complex genetic metabolism. Okay, so you have fast, slow, and intermediate metabolizers. Why is that a problem? Because if you're dosing Ibogaine in the underground or in a clinic and you're not sure how you're working with it, or if you're buying it on the internet, or if you're getting extracts of Ibogaine, you don't know where you fit in this scheme. Okay? Most people are intermediate and fast, but they could be ultra-rapid metabolizers. And this is important for safety. So I want you to hear that, because I know we have some practitioners here who work with Ibogaine. I worked with Scott Obach from Pfizer and Dr. Rachel Tyndall, and we genotyped the patients that went through St. Kitts, and we were able to demonstrate that the duration of the psychedelic experience correlated with the residence time of Ibogaine. Very profound effects in cocaine and opioid dependent patients on mood. So we were able to demonstrate that mood was improved, and we could measure improvement at 1-month follow-ups. So both for opioid and cocaine, it's definitely an antidepressant. Also, we were able to demonstrate that it diminished craving and desire to use, and that was a protracted effect as well. So this is very important because when you think about, again, what's driving the relapse, it's the craving. But it's not only that. It's how you feel. It's your mood, especially if you're self-medicating depression or anxiety. It's also personality drivers, learned experience, the group you're hanging out with, your fear of withdrawal. And withdrawal is the fear of withdrawal is a learned experience, an enduring experience in the brain, so that's going to drive it. And then I mentioned about positive expectation. One more hit of dope, one more line of coke, one more cigarette, I'm going to feel better, and people relapse. Well, what about the psychedelic journey? All right, when I started working with this, I thought, well, maybe we'll just focus on noribogaine, and won't do the transformative journey. And my counselors, blew up at me in the clinic in St. Kitts and said, no, Dr. Mash, this is an incredibly powerful experience. And indeed it is. And what we did is we tried to capture this using anthropologic techniques, and this is in the publication as well. And this is kind of like the top things that people reported to us, but they definitely reported that they felt this helped them to diminish their desire to use drugs. They felt that they were given insight to their addictive behaviors, and the list goes on. But what was interesting, a colleague who was talking about doing Ibogaine, and maybe it's not such a pleasant journey, there weren't that many of my group right after the Ibogaine who said, yeah, I want to go out and do that again. Okay, that was not endorsed. It is a intense experience. Let me go back to this for a second. So let's talk about that psychedelic experience. Well, we know that, neurons that fire together wire together. So perhaps, this is a quote from Michael Mercinich, very famous psychologist, that maybe the psychedelic experience really is important because it's turning on this transformative effect and the cognitive state and engaging the frontal lobe in a way that helps you to unlearn bad behaviors. And of course, there's metaplasticity, as we've learned. And that metaplasticity allows the engagement with the frontal lobe. If you think of the brain as an orchestra, this is the conductor. And when you're hijacked in an OCD loop of addiction, you're in your limbic brain, right? And you're not able to do this. Robin Carhart Harris has exceptionally wonderful data showing with tractography and other fMRI techniques how this may be working. And stay tuned, because Nolan Williams from Stanford is going to be a paper coming out telling us how Ibogaine is really restoring function in the brain. Last year, you come to these meetings because you want to meet people, and I met someone in the speaker lounge who is the CEO of a company called Firefly. And I said, well, if we're going to give Ibogaine and we're going to have it available, we need to have preparation, psychoeducation, and then post-Ibogaine integration, mindfulness, and an ability to go back in to re-experience, if you will, some of the things you learn in setting your intention with the journey. And Firefly and the CEO, who's here in the audience, worked with us to develop the Ibogaine Sanctuary. And I go through this very quickly, but what it does is it helps to, again, as I said, prepare the patient of what to experience, what they're going to be experiencing. It allows them to set the intention, write their own personal narrative, and then finally to integrate it in the most beautiful and immersive setting, which actually, when I used the machine for the first time myself, I cried because I said, my God, this is spectacular, how wonderful to have this. And I really believe that this is state of the art and that this type of VR combined with psychedelics is going to be powerful and will even keep that window of neuroplasticity open perhaps a little bit longer. So I like to say, pre-contemplative, contemplative, and ready for change. Ibogaine in VR. I only have a few more slides. So I've already taught you about this. I've taught you that drug abuse hijacks the brain. Ibogaine is very, very powerful as a rapid addiction interrupter and has a lasting effect on behavior. But there's a little bit of a dark side to Ibogaine, and I would be remiss to not tell you about this. And that is that although we estimate over 10,000 people have taken Ibogaine safely, there are in the published literature, and there may be more than the number, but I reported on this with my colleague, 33 deaths. And these deaths occur because we don't really know the mechanism of causality, but what we do know is that Ibogaine and noribogaine, to a lesser effect, can cause QT prolongation. QT prolongation, what does it mean? It's how your heart resets. Okay, so if you increase it, then you can be at risk for what can be a fatal arrhythmia or a torsade episode. Now, torsade is a rare event. It's a manageable event by a qualified clinician, okay? Magnesium, calcium, potassium must be monitored in the blood before you take it, and of course, you need to take it with a physician, a doctor, who understands this is an investigational drug substance, and they know how to dose it, and they can work with you. If you do that, you take it under medical monitor, we believe, and I believe, and we did 277 doses in St. Kitts, and other clinics have done in the thousands. More than 1,000 veterans have been treated safely. But because of this, because people have taken Ibogaine in unsafe settings, the burden on us with the FDA and other regulatory agencies is very high. It's a high bar. Real-world evidence. Anybody involved in an Ibogaine clinic, get your data. Please, please, please put your data together. Well, we want to pick up the pace, and we will pick up the pace. You know, what I did was working with Ohio State University, and they're excellent people, Dr. Alan Davis. I said, we need a patient registry where people who take Ibogaine can go online, report their experience, and teach us what they did. And that's going to open. You will find this will be online in the next 2 months. And my last slide is just to bring up Kentucky. And you know, we don't know what's going to happen, but stay tuned in a couple of weeks. There is a movement in Kentucky. I presented there, 42 million set aside to help support Ibogaine research. Ibogaine in Kentucky could be a remarkable first step to bring this drug back to the United States and make it available for the millions and millions of people who desperately need it. My fingers crossed. I'm praying that this goes through. We will know soon. And it's money that comes from the opioid abatement settlement, a set aside. There are already people who don't want to see this. Just to point it out, Indivior, who manufactures Sublocade, $1 billion a year, I heard, is being spent in that state for medication-assisted therapy. I want to give a shout out to my colleagues and collaborators at ATAI Life Sciences, of course the University of Miami, who allowed me to go forward, and also to thank Mother Iboga for gifting us an antidote to addiction. Thank you.